I feel like my professor again. I've got my pointer. We heard about the dramatic effects of this treatment in people's lives, but what I wanted to point out is the dramatic effect that this may certainly have in psychiatry itself. The idea of fear of harm presents a paradigm shift in how mental health diagnoses and treatment might be conducted from now on. Oh, that's me. Okay, now, the way psychiatry makes a diagnosis, now I am, this is a non-guild, I'm a neuropsychologist and not a psychiatrist, and so I'm from the outside looking in, chuckling, if I may. The use of psychiatry, the Diagnostic Statistical Manual, is the handbook by which the names of the disorders and their description is presented. And there have been a number of times in which the DSM has been made. There's been the DSM-1, then the DSM-2, and we would have gone on like that until the 70s, in which there were a series of experiments, but Rosenheim is the one that was the most dramatic. Rosenheim published this in Science in 1973. There was a series of studies, but the most dramatic was he sent normal people to different hospitals complaining of having hallucinations and thereafter just acting their normal self. All of them came out with a diagnosis of something akin to schizophrenia, sometimes in remission, sometimes with other things, and all were giving psychotropic medication. So, having published this, a number of hospitals, but one in particular, said, you know, if you send them to our place, this would not happen. So Rosenheim, he said he would do so. And so of the first 250 patients in this hospital, 40-something or something were diagnosed essentially as detected of being pseudo-patients, not really real. And it turned out that Rosenheim had sent nobody to those hospitals. And then it essentially published and came to the conclusion side that they can't make a psychiatric diagnosis in a psychiatric hospital. Thereafter, a number of other things seemed to come out, which went through psychiatry. In the 70s, I was still in neurology at that time, listening in through the other side, the walls were thin. And a number of studies started coming out about the reliability, how psychiatrists couldn't make the same diagnosis in New York as they could in actually the Bronx. And then the same psychiatrist given the same data is likely to come to a different diagnosis second time around. There was no reliability and seemingly no validity to the discipline, which prompted the DSM-3, which was a major rehaul. And what they did essentially was decide by committees what diagnoses there ought to be. And it was important that if you look at the third part, as one of their novel approaches to this, it's an approach that attempted to be neutral as to cause. That means it was agreed there was no cause to these disorders, and the purpose was to increase the interjudge reliability of the diagnoses. So the classifications were determined by committee. These were experts, agreed upon by their peers, by other people in the field. These were not people kind of on the fringes. These were mainline people who agreed that there was such a thing as, say, a depression. And then the classifications were developed and made specific so that there was high interjudge reliability, but there were no criteria for validity. And to this day, you have DSM-5, which is the latest iteration, and you can have, for depression, you can have 5 or more of the following. So you can have a depression with depressed mood, with diminished interest, significant weight loss, and maybe psychomotor retardation, and you would be called depressed. Everyone would agree. But also, you could have recurrent thoughts of death. You could have inability to concentrate. You can have loss of energy, and you can have psychomotor retardation, and you also would be called depression. So the problem that the field presents to science is that the population of depression is a heterogeneous population. And if you want to do studies, what you're going to find is a lot of noise in your data because you're not really dealing with the same kind of disease, even though they're all called depression. So, we have now a paradigm shift. The paradigm shift is that fear of harm was not developed in this way. And what we have is a disorder that has a cause. It is not cause neutral. We're postulating that there's a thermoregulatory disorder that underlies the cascade of difficulties, which is the pathophysiology of this disorder, and we have a biomarker for it. I'll get to a biomarker later, but it is independent of whether or not the patient is depressed or is complaining of, is thinking, whatever he's doing, their biomarker is independent of the presence of other psychological factors, which is one of the problems in the DSM-4. If a patient comes in and says, I'm helpless, I'm hopeless, I want to kill myself, you don't admit him for depression, then you're kind of liable at this point. And the next person coming in with saying almost the same thing also is going to be given a diagnosis of depression. And the drugs that affect them may be, in fact, quite different, but you don't know that from the diagnosis. In this case, we have a treatment that is based on the nature of our understanding of the disorder and how it comes about. It is not a medication that, when used in mice, allows them to run around to the right or to the left, meaning it probably treats psychosis better than maybe another kind of drug. This has a reason for being. And the biomarker is I just wanted to get to. It is a test, whereas you can test the presence or absence as you would in any other medical condition. You think that there's a virus, and you can test for the antibodies for that, and you have a hypothesis, you test for it, you may have a treatment for it. We have a biomarker. The biomarker is the relationship between core and peripheral temperature. And we can test that, and we can see whether it's normal or abnormal. What we have then is a diagnosis. It's a medical model diagnosis, and it can be proven. But more important, for scientific purposes, it can be disproven. The whole purpose of science is to place a hypothesis, being able to test that hypothesis, and being able to test whether that hypothesis are true or false. This is, to the best of my knowledge, the first diagnosis that has a medical model that can be proven or not to be a valid diagnostic disorder. And thank you.